Hi, everybody. Welcome to our session. We're going to start here while people continue to trickle in because we have some great presenters and we want to make sure they have enough time. This afternoon, we're talking about trauma-informed care for the healthcare team. I'm Mary Beth Prier, and this is Rachel, and we are co-facilitating, and here are our disclosures. These are our objectives today to talk about the signs and symptoms of medical traumatic stress, to recognize the impact of trauma on our health and well-being, understand symptoms and signs of medical trauma, learn about some different strategies, and also think about gender-based violence and how that presents within our patient family systems. These are our presenters. I'm sorry, Megan, that is the wrong. I tried to change it to PhD. So Megan is going to be both today, right? But we're excited to let each of them talk for around 25 minutes, and then we'll have questions after each presentation. And at the end, then also allow some discussion. So first up is Dr. Megan Marsak, and I'm going to do a quick introduction for her. So, Dr. Megan Marsak is a pediatric psychologist, a tenured associate professor, and the division chief of psychology in the Department of Pediatrics at the University of Kentucky and Kentucky Children's Hospital. She also serves as the associate director of the Center for Pediatric Traumatic Stress. Dr. Marsak's program of research centers on medical trauma and includes conducting grant-funded studies to identify predictors of emotional and physical outcomes in the context of acute or chronic medical conditions, developing and validating assessment tools, and creating and evaluating programs to promote recovery and/or adjustment to medical conditions in children and families. Dr. Marsak is a leader in the field of pediatric medical trauma, having published over 70 academic articles and 10 chapters on this topic. She has co-authored a book for parents to use to help support their children through medical care, as well as to care for themselves. It's called Afraid of the Doctor: Every Parent's Guide to Preventing and Managing Medical Trauma. She currently serves on the editorial board of the Journal of Pediatric Psychology and the Journal of Traumatic Stress. Dr. Marsak has also given hundreds of talks on understanding and promoting adjustment to injury and illness in children and their families. She is the CEO of the Selly Coping Company, which has distributed over 2,000 coping kits to families with children with medical conditions. In addition, she specializes in training medical teams in the implementation of trauma-informed medical care. Clinically, Dr. Marsak implements evidence-based practices to facilitate families' management of medical treatment and emotional adjustment to challenging diagnoses and medical procedures. So welcome to you.
All right, good afternoon. Thank you for joining us after lunch. I will say, as part of trauma-informed care, we talk about our own well-being as well. So if any of you choose to take a nap during this presentation, I'm going to assume that it's for your own well-being and not because we bored you in any way. So naps are accepted. If you start snoring, we might have to have a little discussion there. But thank you so much for joining us. We're really excited to be here with all you. I'm feeling my height here too. I can't quite see this side of the room over here, but I look like this. We will move along and talk about what does trauma-informed medical care mean. And in this presentation, what we're talking with trauma-informed medical care, we're talking about the emotional impact and emotional trauma. So sometimes that comes along with physical trauma, but here we're really focusing on how does our healthcare, how do our medical conditions affect us emotionally, and what can we do as a medical team to try to mitigate that? Yeah. Okay. All right. I'm going to get the hang of this technology up here. Nothing to disclose relevant to today's presentation. When we talk about trauma-informed medical care, and as you listen to the talks today, I think it's really helpful to think about your own experiences as a medical provider or family member or caregiver or whatever capacity you're joining us here today, and try to think about how the material that we are presenting might relate to the patients that you work with or the families that you work with as well. And it brings it home, makes it a lot more interesting. So thinking again about today, how we're going to define trauma-informed care and medical traumatic stress. We're going to talk about kind of these three components of trauma-informed care. And so when we think about trauma-informed care, we think about realizing the impact. How common is it? How many of the patients and families and our colleagues and everyone that we're interacting with, how common is it to have reactions to our medical care, medical conditions, and also how common is it for us as healthcare providers to have reactions to the care that we're providing and what we witness in our patients and families as well. We're going to talk about how we recognize signs and symptoms of medical traumatic stress in the kids and families that we work with. And we're going to talk about a little bit what kind of strategies can we implement to try to be more trauma-informed through a whole systems. When we think about trauma-informed care, we really want to integrate and make a culture shift such that at every point of care that a patient experiences, they're met with a trauma-informed approach. So thinking about that from that first phone call that they make, all the way through the checkout and scheduling their next appointments. And in thinking about in the settings that you work, where are the things that can kind of go wrong with that and what kinds of strategies we might want to put in place to help mitigate that. Today, I'm tasked with laying the foundation for this, and then some of my colleagues here are going to give some specific examples of how this relates to some of the work that they're doing as well. So thinking about first, what is medical traumatic stress? Have all y'all heard of this? Is this a common term for y'all? Yeah, hands up if you've heard this term before. That's super common. You guys are all on top of this. Okay. So when we think about medical traumatic stress, we think about it as being both physiological and psychological reactions to kind of all the things that go along with medical conditions. So it can be diagnosis, it can be bad news. It can be, oh, you're going to be in the hospital this weekend. You're missing your sports, or you're missing your dance, or you're missing, some other loss in the family. It can be to different kind of medications. And we'll talk a little bit about for individuals with CF, particularly pediatrics here. We're focused on pediatrics, but this also in our work that we've done, but this also extends to adult patients about some of the experiences patients with CF have shared with us about kind of how different parts of their treatment can trigger these emotional responses, even when us as medical providers might not think that that's a traumatic part of care. So the other way I like to just think about it is it's emotional reactions to scary medical stuff. With the scary being the perception of the child and the healthcare team, not necessarily what we as medical providers would think is scary. Oops, I'm doing it again. I like to click, and instead of, I gotta push some other buttons. I noticed that some of my animations might be slightly adventurous. All right, so there we go. So today, as we walk through medical traumatic stress and trauma-informed care, we're going to talk about Tina. Tina is a 13-year-old female with recurrent exacerbations with her CF. The reason she's referred to us in psychology is for non-compliance. We know a little bit about Tina's history, but not a whole ton when we first meet Tina. We know she has a single-parent home. Her family has 2 other siblings in the household. She's got some mild mental health history with some mild anxiety over time. She struggles in school a bit from time to time, but is overall kind of doing all right. So we'll talk a little bit about Tina and kind of what we learn about Tina and what we learn about how this non-compliance might actually be related to like an actual trauma reaction over time. So again, thinking about our overarching kind of plan of care and what do we need to change in our whole system when we're working with patients and families. So one of the things that we talk about with the patients and families that are coming to us, as well as what we bring in as healthcare professionals, is everything else that's going on in our life, everything else that's gone on in our history and our world. So thinking about when we talk about trauma, what kind of culture or political trauma? We don't really even need to mention that today in this room. There's so much going on currently in our world. And I think that there probably always has been, with other things kind of popping and highlighting over the last 5 to 10 years here. We think about historical trauma. So what are things that has happened in an individual family's history or ancestry that might bring them to experience things in a different way than what we would anticipate them experiencing? And we think about transgenerational trauma as well. You probably have in mind potentially some families where, it just seems like they've always had a rough go. They have really low resources. They've had historical, really bad things happen to that family. And we've seen some actual data over time that they can kind of pass down some of that trauma over time. So thinking about this as kind of our foundation as well when we think about trauma-informed care. So when we think again, like looking at that widespread impact of trauma and understanding potential paths for recovery. So there's two kind of pieces as medical care teams or people that are advocating for individuals with CF to think about when we think about what are we walking in with. We can think about pre-existing exposure to emotional trauma. So what's already there? What has happened in this child's past? What's happening in their community? What's happened in their school? Adults too. And so for those of you that work with adults, what has happened in this individual's history that they're walking through the door to our medical facility with? Then we think about in the care for CF and in the work that we're doing to try to give them the best quality of life, the absolute best physical health outcomes, where are the areas that we might either re-traumatize or trigger something that's already there or create new trauma for these individuals in the nature of the care that we're trying to optimize for physical health. We can think about this also for professionals. This is not a secondary traumatic stress talk exactly, but I want to put a little plug in to think about that for yourselves and your teams as well. When we do full hour, 2-hour, 4-hour workshops on trauma-informed care, we always include the providers and the caregivers as well. Thinking about what you're bringing in with you to every patient encounter that you have, what's going on in your personal life. Medical providers are human too. We've all got stuff. Most of us have not grown up in a bubble, so we've got our history we're walking in with. We've got whatever's going on in life right now, and that interacts with our patient care. So making sure that we're aware of ourselves and aware of how that might be impacting our care or ourselves. And then in a similar vein, what are the things that might be hitting us as medical providers from the things that we witness? And some of the talks earlier this week, earlier today, gosh, it's been a long couple of days. I'm all time changed up. I don't know what's going on. So I think it was just this morning I was listening to some of the case stories where, we lose patients, and sometimes in really bad ways. And sometimes in ways where we know as a healthcare team, if the patient were to follow the protocols that we can put in place, the outcomes are going to be better. But they're not following them for whatever reason. And so we carry those kinds of things with us too. So thinking about both outside the job, what's happening to me, and inside of the job, what's happening, and making sure that we're taking care of ourselves as well. So being aware of that for ourselves and being aware of that for our teammates also. So thinking about Tina, again, remembering that Tina's major problem from the medical team's perspective is that she's not being compliant with her care, not doing the vest like she's supposed to, not taking her meds that she's supposed to. So she's coming to us and they're like, this is just a teenager being difficult. So we learn a little bit more. We learn in teenage family, there's a lot of challenges with finances. So single parent home, single parents really struggling to get food on the table, to get manage the copays with the medications, to is working extra jobs and is not necessarily home as much as we would want them to be home to be able to enforce a more rigorous protocol for helping through taking medications and staying on track as the medical team wants. We learned that Tina actually has an abuse history as well that we weren't aware of in the past. So she's been coming to us, not in the context of her medical care, but in her other personal life has had an abuse history. We also learned that she's really anxious around new people. And I don't know about for your medical teams, but for ours, we often have like trainees rotating through, lots of new people. Every time they come, they might be meeting new people. So that really has an ability to impact care. We also learned that her treatments are reminding her of CF. Like many 13-year-olds, she doesn't want to acknowledge that she has CF. She wants to live her life, go be with her friends, do slumber parties, be sleepovers, just be out and about, living her life. But every time she has to take her medication, every time she puts her vest on, it's making her feel like she's a sick child instead of a regular old teenager. And so she's actually kind of getting triggered and having emotional reactions and anxiety each time she's doing her treatment. She really loves music and soccer, we also learn, and the condition that the toll that CF is taking on her right now, especially with her noncompliance, is getting her in the way of her doing the things that she loves. So a little bit more. So when we're thinking about, okay, first we think about Tina as this kind of really difficult teenager. Oh, she's 13, here we go. But then we actually learn, okay, actually this is anxiety-based and triggering-based, not necessarily non-compliant-based. Well, still non-compliant, oppositional-based. With that information, it helps us have a better idea of what kind of treatment and how to support her, not just as a psychosocial team, but also as a medical team partnering together. So thinking about, all right, so we realize it's there, it's prevalent. I think we had a presenter that's unfortunately no longer able to present today that was going to give us all these beautiful stats. So here are the stats in my head from what I know from the research that we've collaborated on for CF. Around 30% of individuals with CF report significant symptoms of medical traumatic stress. And so if you think about the folks that walk through your practice, thinking about, okay, that's like 1 in 3 or 4. How many patients do you see in a day? How many of your families are kind of struggling with that? And it's not just our patients. It also is siblings of our patients, parents of our patients also have symptoms of medical traumatic stress at about the same rates. So keeping that in mind as we're kind of navigating throughout. So then thinking about, okay, how do I know? What does medical traumatic stress look like? When it walks through my clinic doors, what do I see? If I'm caregiving or advocating for individuals with CF, what are the things I want to share with the community so that other parents, other caregivers can think about, oh, wait a second, I heard about this. This is medical traumatic stress. I'm not a crazy person. And I can't tell you how many patients that we've worked with where they go from feeling like I am crazy to, oh, there's a name for this. This is a thing that happens, and trying to destigmatize that for our families. So medical traumatic stress looks like post-traumatic stress. So if you think about most of our research came on PTSD, came out of military, research with our veterans. These same clusters of symptoms are what we see in our kids with CF, in our adults with CF, in our family members of those with CF. Things like re-experiencing, having things pop in their mind, thinking about changes in kind of cognition alterations, kind of that shift into like everything's bad, everything's negative, the world's a scary place, being afraid to do things, avoidance, and we'll talk about in the next slide some specific examples of how this all pops for individuals with CF. Increased arousal and what that looks like. So thinking about what have we learned from individuals with CF who've shared kind of their lives and their stories with us. Re-experiencing, so they have intrusive thoughts sometimes. They're just trying to some of our teens trying to go to a dance or plan for a dance. They're like, well, what if my CF flares up and I miss the dance? What if I can't go or I start to get sick? What if I start coughing a ton? What if, all the things, all of the pieces about CF. Unwanted memories about treatment, sicknesses, unwanted memories about missing out on big parts of their lives, consistent with adults too. They have similar things that they're missing out on because their CF is acting up, or they have ideas about what that looks like for them. So those things just kind of pop in your head. Sometimes it comes out in dreams. Sometimes with younger kids, you'll see it in their play. They'll act things out, or you'll see it in their drawings. The same kind of things around alterations in cognition or mood. We'll see it come out as anxiety sometimes, or just a negative mood. One of the things that's come out of some of Dr. Caneo's research is this concept around survivor guilt, and many of you probably are really familiar with that clinically as well. So, if your CF isn't as bad as your brother's CF, or if you know others in the community that have suffered or who have passed, but you're doing really well, like kind of carrying that with them. Sometimes we'll see changes in moods during hospitalizations or during appointments. So where you have somebody who's doing pretty well unless they have to confront their CF straight on. We've got some kids and teens sometimes, they come in pretty good, hospitalized day 1, we're all right, day 2, and you watch it start to kind of decline over time. And the longer in their hospital stay, the worse it gets. Things like avoidance are super, super important for CF. So this one, if you forget everything else from today, kind of putting this in your mind and taking this with you. When we have things like taking medications, showing up at the doctor's, coming to the clinic, triggering emotional responses such that it feels like anxiety and panic, this can result in our kids and families avoiding all of those things. So sometimes when we have situations where somebody's not being compliant, they could just not care, not be compliant, and be like, screw this, I'm not doing this today, I've had enough. Or it could be other pieces of their kind of experiencing CF or parts of CF as traumatic, that makes them then engage in these other behaviors. So thinking about that for your team, especially when you get to know patients and families for a long time, keeping an eye on these sorts of things as you're kind of working with families over time. This also can be helpful to educate families around as well, so that they can have a sense of like, oh, that's normal to not want to come to clinic or for the clinic to stress me out sometimes. Not over-pathologizing, not saying everyone with CF is going to have PTSD, but just saying here are some stress reactions that sometimes people have. The other thing that can be really important for medical teams is that increased arousal, because sometimes we'll see those elevated vitals, and we're like, why are they elevated every time they come in? You know, there's all that white coat study that's been in the medical literature for years and years. Sleep problems can pop up as part of this, increased irritability. The thing that I think is also really important when you look at that increased irritability piece, if you've got a kid or a family or an adult patient or a sibling, anybody in the room that's got that heightened irritability, and then you got to come in and say, I'm sorry, you got to you have to be hospitalized. And maybe you're irritable that day too, because maybe you've had, a real fun day full of real fun patients. And you enter in that space, that's not a great place for great work for anybody. And so thinking about, when do we recognize this and how do we help our kids and families over time so that they don't have that piece hitting on them? So a little bit more about Tina and what did this look like in her case? So again, we learn a little bit more around, she was having sleep trouble too. So looking at these other symptoms, really hard time falling asleep at night, getting stuck in those thoughts about CF and trying to avoid them at the same time. So she's in the cycle of like, avoid all day, don't take my medications, because if I take my medications, I feel worse, I feel anxious, I feel more irritable. So then I'm going to avoid it. I'm not going to think about CF at all. But then I lay down at night and all I can think about is my CF circling around and how I didn't take my medications today. And that means my doctor's going to be mad at me. That means I might be in the hospital more. I'm going to miss more dance, more music. So she got herself stuck in this cycle of trying to avoid and then having that re-experience and kind of pop back up for her. She also had some trouble with some of the medical procedures and like blood IV starts when she was in the hospital. And so she's got kind of some of those things kind of popping around in her mind as well. She tries to avoid interaction with the medical team. Classic avoidance symptoms. I don't know how many of you might work in the inpatient setting, but the fake sleepers, classic. And sometimes that's maybe just a teenager, maybe just a shy kid, but also can be a sign of like, I'm trying to avoid and pretend this isn't happening. You put me here, and then sometimes we'll have some patients that it'll be a certain team member or a certain doctor or a certain, they'll decide that's the evil one of the bunch. And to try to think about, okay, it's not about me, it's about what we're doing. But sometimes also kids that even in clinic, if they won't look at you, won't engage in their care, like mom can answer, dad can answer, aunt can answer, whatever we do, I'm not answering because I don't want to think about this and I don't want to acknowledge how real this is for me. So that can be a symptom sometimes as well. This also can happen with caregivers of folks, the ones that never seem to be there when you're rounding. You're like, oh, we have this really important piece of information, or that you can't get on the phone, you just can't. It can also be a symptom of traumatic stress for those caregivers. Quick note, in case you're really interested in this, as far as healthcare providers, we see really similar reactions in healthcare providers. If anyone's interested in learning more for healthcare providers, healthcaretoolbox.org is a website that has a whole bunch of information on, there's additional free CEs for nurses for training in trauma-informed care. There's some other free online resources. There's free handouts for patients and parents in both English and Spanish. And so if that's something that your team is interested in, either in diving in more and learning more about secondary traumatic stress or those kinds of things, or getting some educational handouts for parents, that's a great one to dive into. But the one thing I'll point out here just real quick is red flags of trauma reactions in healthcare providers. I don't really want a provider that's having difficulty making decisions, that's having impaired memory and confusion, decreased concentration. If they're feeling really overwhelmed, I want you to go take care of yourselves and come back to me and give me your full attention. So if you're not someone who can get on board taking care of yourself for yourself, your family, your life, get on board with it for your patients, because they deserve to have you at your best too. So slight plug for that. Again, I will not harp on that too much today, but if you catch me in another setting, I might. So that brings us to kind of what can we do? So our goal in implementing medical trauma-informed care is to minimize the traumatic aspects of care that we're delivering, thinking about when we're doing treatments and procedures, what are the things that we can integrate in systematically that's going to decrease anxiety and be our baseline of treatment for everybody. We want to maximize positive interactions between our providers and family members. We also want to do screening. So the CF Foundation has been fantastic about pushing for screening. In addition to screening for anxiety and depression, I concur with the younger screening that other talk of us here today, screening younger, and then also considering screening for medical traumatic stress and keeping an eye and ear open for that. We want to support adaptive coping in our families that are already there and figure out who needs more help and how are we going to get them to more resources. So just kind of an overview, again, thinking about these are the kinds of things we want to think about in a trauma-informed care system. We want to make sure our patients feel safe to share with us, safe to talk to us, that they have that trust with us, building in that. Thinking about how do we integrate peer support can be a little bit tricky with CF, given some of the restrictions about connections. So thinking about creatively, what kind of online venues can we create and connect people together. Figuring out how do we collaborate with the family on their care so that we're not just telling them what to do, we're partnering with them and making choices about what works for them in their life, making sure they feel empowered. If we start, especially with our younger CF patients earlier and earlier, and having them try to feel empowered along the way, then as they advance through those teenage years, hopefully they're empowered to make great choices and feel comfortable with their CF care over time. And we need to make sure that we're considering all the cultural, gender, and historical issues that each of our families is coming in with. When we think about where to intervene, we know that, well, see, look, that's a little special animation there. But our entire healthcare team can be involved in universal supports, so integrating trauma-informed care systematically, providing education throughout a patient's care. Thinking about targeted, there's things you can do as physicians, nurse practitioners, dietitians, nutritionists, social workers, psychologists. Everybody can do some things to help monitor child's distress over time and help provide some specific interventions built into standard medical care. And then when we get to that clinical treatment range, that's where you definitely want to consult and work with mental health providers. Really quick plug for what can you do for yourself and thinking about yourself. We want awareness. Be aware of your reactions to stress. Think about balancing, how do you diversify your time, and think about connection for yourself. So those are kind of the three buckets that you can think about. So bringing this back to Tina, what can we do for Tina? So again, thinking about communicate with the medical team about treatment refusal. So one of the first things that we did for Tina is talk to her medical team and helped share the information that actually Tina's really afraid and anxious. She's not refusing this because she doesn't want to do it. She actually really wants to comply, but is really struggling. Bringing the medical team together. So for example, in a case where they're afraid to meet new people, maybe the residents don't go in if they're rotating through every time. Maybe we don't include medical students. Maybe we kind of try to make a small partnered core group for this situation, for this kiddo. We help Tina re-engage in her social activities. We know those are supportive for her. We integrated her in trauma treatment, not just for her CF, but she also has that abuse history that's gone untreated and under-recognized. So engage her in trauma treatment so that she can begin to deal with some of that as well. Provide her, the parent, some support around how do you advocate for your child and how do you support her through this. And then thinking about, as a medical team, sometimes these are really, really hard cases. And how do we support each other through this as well? A quick note about when to get more help as medical providers, or really anyone, but any adults. If your work is getting in the way of your life, if your life is getting in the way of your work, those are both times to reach out. There's great evidence-based therapies that can help get you back on track so that it's not interfering with your goals. Thinking about any self-harm or harm to others, definitely a time to reach out for more help, or if others are concerned. Many people in the helping field are really great at shoving it down and just kind of going on. But if you have other people saying, "Are you okay? Gosh, you've seemed a little," and instead of snapping at them, maybe taking a minute to say, "Do I need to check in with myself? Am I really okay?" And that brings us, I think we have a couple minutes for questions now, unless I talk too long. Yeah. A couple minutes for questions now. Yeah.
Thank you, Megan. We have quite a few questions about people are interested in how do we diagnose medical traumatic stress versus PTSD or ASD, and are there any tools that can actually help us do that? So can you talk a little bit about that?
Yeah, so you could diagnose a patient with PTSD with their identified trauma being the medical event or the medical medical care, kind of whatever is driving that. And that could be accurate. So there's overlap with them. We talk about medical traumatic stress in one part because it's a little bit more destigmatizing because we see it so commonly. And so one of the reasons we often will frame it that way for families is it really makes it part of their overall healthcare and mental health care together. And that kind of some of the reasons for some of these struggles are related to their medical condition. So you don't really have to sort it out if you don't want to. You can diagnose PTSD if that feels right for the family or the patient that's in front of you. So some of the screeners, there are some CF-specific tools underway, under development. Dr. Addison Canio is working on those currently. Alternatively, what we use right now is PTSD or acute stress disorder symptom screeners, because you can look at those symptoms and things like the CPSS, or there's a really brief screener. If you look on healthcaretoolbox.org, there's a whole list of like screeners that you can use, and we'll tell you which ones are free and kind of what they assess to.
Okay. Do you have any thoughts about getting parents and providers to acknowledge that something is potentially traumatic to the patient? Sometimes that can be difficult to do.
Yeah, it can be real difficult. I concur there. I think sometimes the way that, depending on the language we use, sometimes we don't use the words traumatic. Sometimes we might use the words, this seems really hard or really stressful, if we have either a medical team that doesn't really have the same formulation around trauma reactions that we might have. So we'll kind of frame it in a different way, because the most important thing is if you've got a kid or an adult who is struggling and needs support with whatever the symptom is, we got to get them help with that symptom. And so framing it on just like you have symptoms for your physical health that you need to address and there are treatments for those, we have these symptoms that is part of our physical health that's also emotional that there's treatments for as well. And so maybe not framing it so much as trauma if that seems to be getting pushed back, but more about symptom-based and putting it in the medical model.
Okay. How do you partner with your psychosocial team members, example, child life social work, to harness the power of prevention and intervention early?
How do I want to, or how do we do it? We're still working on building in our institution. We're small and growing rapidly. And so I think that there is definitely a role for all members. I think when we've been kind of the most effective is when we're all partnering together. For example, sometimes I'll come in and do like an assessment and identify, like for needle sticks or port access, here is the problem, let's create a plan. And then Child Life will partner and they'll be there and they'll implement the plan sometimes, and do reward systems. Sometimes our Child Life folks can do that individually, but then if they hit a like, this isn't working, then they'll kind of call in for more help, and we'll work together to kind of identify what's been tried and are there ways we can tweak the plan. And social work too with psychology. I think sometimes with our social workers too, we'll even divide and be like, okay, you're going to be the primary support for the parent family. We're going to be the primary support for the child. And we're going to maybe even implement the same evidence-based practices or treatments, but to different family members so that everyone feels like they've got somebody. And then we're going to kind of bring the family together in that way. But I think for us, really, the communication is just the key, making sure that we know what each other's doing and we support the efforts of all of us. That's when it goes the best.
Okay. All right. Great. Okay. Thank you so much. All right. Next up, we have two presenters who are sharing the stage, but perhaps can stay seated one at a time, right? First, I will introduce the two of them. I had the pleasure of working with them before, and I'm excited to see them again. So Brooke Jones is a licensed clinical social worker and a current PhD student in the Maternal and Child Health Department of UNC Chapel Hill. Her primary research interests are health behavior, maternal mental health and gender-based violence. She has worked as a mental health clinician within the healthcare, campus, and nonprofit settings. She's been committed to the care of those living with CF since 2016, when she was hired as the mental health coordinator for the UNC Adult CF Center, where she provided both mental health and substance use screening as well as psychotherapy. She later transitioned and joined the study team as a therapist related to the multi-center study, Coping and Learning to Manage Stress with CF, where she provides stress management skills for those living with CF. Related to gender-based violence, she worked for a local domestic violence and sexual assault organization for more than 5 years, and most recently at Duke University as a gender-based violence interventionist. And her co-presenter is Mary Ann Buchanan, who is a licensed clinical social worker and has worked in a variety of settings over the past 20 years, always with a focus on serving the underserved. She joined the CF team at UNC Chapel Hill in 2017 and was involved in starting initiatives to address advanced care planning, food insecurity, as well as behavioral health needs. She is currently working as a study coordinator and therapist on the CALM study and as a therapist embedded in her local homeless shelter. In her work within the CF community, she has been struck by the varied reports of gender-based violence within this patient population. Given the lack of research on this topic, she and her colleagues feel the strong need to further investigate and address this problem. So welcome to both of them.
Okay, good afternoon, everyone. Thank you for being here today. My name is Brooke Jones, and I'm joined, of course, by my colleague and friend, Mary Ann Buchanan, for the presentation. Before we get started, I just want to take a moment to take a collective breath and really kind of ground ourselves in why we chose this particular session to attend. And I also want to take a moment to just acknowledge that we're speaking about gender-based violence and more in depth about intimate partner violence. And unfortunately, IPV is very common. It affects approximately 1 in 4. So that means there are likely several folks in this room who have experience with intimate partner violence. So please, take care of yourselves in whatever way that you need to and that feels meaningful to you. Oh, no. Okay. We have no relationships to disclose. All right, so now to get us started, I just want folks to think about these numbers and to take a guess at what the significance is regarding the number 84 and 1500. And if you're feeling particularly social, maybe turn to your neighbor and, just share what you think those numbers are. No one's feeling social. Got it. Okay. A lot of introverts. It's cool. Me too. All right. So the number 84, so that is the number of people who were killed in Arizona related to intimate partner violence in 2022. So just last year. And I chose Arizona because that is, of course, where conference is this year. 1,500, that's the number of deaths that intimate partner violence is responsible for in the U.S. annually. So for me, this topic is really critical because of the impact even one death has on the community and the loved ones. So let's kind of zoom back out and talk about gender-based violence. So gender-based violence is the umbrella term. So that encompasses many different types of violence that are directed at a person because of their actual gender or because of assumptions made about their gender or gender identity. It stems from gender inequality, and it can affect anybody, but it disproportionately affects those who identify as women and girls. Also, in terms of the LGBTQ community, that community also really experiences high rates of intimate partner violence, and they often do not report because of concerns related to stigma or safety. Gender-based violence is also used to describe violence specifically against the LGBTQ community when discussing violence related to not meeting gender norms. So I want to make that distinction. In terms of types of gender-based violence, so what types of violence fall under this umbrella? So scholars recognize that there are different forms that include physical, emotional, economic, and sexual violence. I'm sort of assuming that folks are more familiar with physical and sexual types of GBV, but related to emotional violence, you can think about intimidation or threats, humiliation, isolation, confinement. With economic violence, you might think about discrimination or denial of opportunities, forced marriage, denial of education to women. And I have more to sort of come in terms of details about types of violence in a few more slides. One of the things that I think is missing here that's really prevalent for folks that we work with is digital dating violence. So that's also something to be thinking about. I know definitions are pretty dry, but they are really important in terms of how we define things is how policies and procedures are going to be set up. Okay, so if we are only looking at IPV as physical violence, we have a real limitation. So just to briefly go over those, intimate partner violence is defined as behavior within an intimate relationship that causes physical, sexual, or psychological harm, includes acts of physical aggression, sexual coercion, psychological abuse, and controlling behaviors. Ultimately, power and control is sort of at the center of that relationship. Survival sex, that is defined as trading sex for basic needs like food, money, or shelter. Sexual violence, it's an all-encompassing, non-legal kind of term that includes crimes such as sexual assault, sexual harassment, childhood sexual abuse, and rape. And then human trafficking, that's defined by the U.S. law as the use of force, fraud, or coercion to compel a person into a commercial sex act or labor against his or her will. Okay. So I want to get into a little bit of statistics. So in terms of the LGBTQ plus individuals, those in college, they are up to 9 times as likely as heterosexual individuals to experience IPV. 14% of women and 5% of men report having been stalked by an intimate partner. About 1 in 5 women and 1 in 13 men have experienced contact sexual violence by an intimate partner. About 1 in 3 women and 1 in 4 men report having experienced severe physical violence from an intimate partner in their lifetime. 44% of lesbian women have experienced rape, physical violence, and/or stalking by an intimate partner. Only 26% of gay men have called law enforcement after experiencing near-fatal violence by their partner. And trans people are more likely to publicly experience intimate partner violence or domestic violence than those who do not identify as transgender. And this, I think this is really interesting in thinking about our CF population. Women and girls with disabilities are 2 to 3 times more likely than women without disabilities to experience gender-based violence. And for those of you who work with college-age folks, 1 in 5 in college is sexually assaulted. And this last one, this slide, I want to point out this is just about arrests by state related to human trafficking. This comes from the FBI. So the darker the color in terms of gray or blue, the more arrests. So I'm from North Carolina. That darker gray, there's 56 arrests in 2019. Interestingly, North Carolina is ranked, I think, number 9 when it comes to rates of human trafficking because of the interstate corridors and international ports. So in thinking about this, and in terms of kind of the framework that was set up of realizing and looking through the trauma lens, even if you weren't aware of the stats, I'm hoping that, through these, you're considering your patient panel right now. And you're wondering, and what I'm wondering is if this information alters your perception of your CF patients that you work with, what maybe they're experiencing, and what maybe they're coming into clinic with. And so, when we talk about irritability and we talk about some of these other symptoms, this is an important context to have. I won't get into too many of the details, but I feel like it's really important. I can't talk about intimate partner violence without bringing up the power and control and the equality wheel. Just a quick show of hands, are folks familiar with this? Can you raise your hand if you're familiar with the Duluth model? Okay, great. I'm really glad to see that. So, this is used by advocates to really pull out and to explain kind of the dynamics and what is similar across relationships. What are these patterns? And so at the outside circle, you can see physical violence and sexual violence, which is really important to note. It's not necessary for physical or sexual violence to be present for it to be intimate partner violence. But there's these other terms, these other things that can be going on. It can be, a partner using isolation, so controlling what she does, who she sees and talks to, what she reads, where she goes, minimizing, denying, and blaming, using children, using male privilege, using economic abuse, using coercion and threats, using intimidation. And then at the center, it's that power and control. Similarly, or kind of on the conversely, really, we have the equality wheel. And so that's where there's this nonviolence on the outside. In the center is equality. And we're talking about shared responsibility, economic partnership, negotiation and fairness, non-threatening behavior, respect, trust and support, honesty and accountability, and responsible parenting. So these are really, really useful in the context of working with folks. If you're doing psychotherapy and you have somebody that discloses IPV, this is something that is out there and really useful as a tool. I will say, I love these wheels. I use them all the time. But one limitation to them is the use of heteronormative language. So the creators of the Duluth model, they maintain its use and discuss it on the website. And their view is that the model works in the context of abuse between a man and a woman. And while they haven't adapted it, there are others that have adapted this wheel to talk about power and control within same-sex relationships. So I do just kind of want to mention that. So in terms of recognize, and in terms of the process that Marianne and I went through and recognizing what was happening within our adult CF clinic, we started in 2016 as mental health coordinators. And we both, as you've heard, had kind of previous experiences working in the field of trauma. And, when we came in, we were tasked with screening for depression and anxiety. And then we recognized pretty quickly that, because of comfort or access to care and financial copays, those things, there were a lot of people who really preferred to meet for psychotherapy and to do that virtually. And so we started providing that, which was really useful. And in the context of that, as we were doing our intakes to start therapy, we were providing a full assessment that included a trauma history and safety questions. And so, just in discussion, we noticed that both of us had individuals who were reporting a history of current intimate partner violence. And so this is a screenshot of a poster that was presented in 2017 at NACFC, where we discussed that CF really can be its own barrier to leaving a violent relationship. And so that brings me to the question that we often hear when talking about intimate partner violence, which is, well, why don't they just leave, right? And number one, that is not the question we should ask. The question really is, why does an individual in a relationship hurt their partner? But aside from that basic point, the point is that there are many structural barriers that make it difficult for anyone to leave, regardless of CF status. But there may be more unique barriers for someone who is living and managing their CF care. And so, thinking about like needing to remain near their CF center, or thinking about, I know many of my patients, their partner was the primary subscriber for insurance. And so leaving would have been a real barrier. Transplant is really tricky in this context. If you have to have two caregivers and you're disqualified from transplant, if you don't have two caregivers, you're not going to feel comfortable to disclose what is going on, right? That is something that you're going to keep to yourself, and you're going to try and manage it the best you can. And then, we are pretty limited in terms of access to safe housing, right? There are homeless shelters. I know in North Carolina, we have a DV agency in just about every of our 100 counties. But some are dual services. Some have very few beds for shelter. Some have no beds for shelter. And so there is that component. And then even if you are leaving to potentially go to a shelter, what do I do with all this expensive medication and, with all my equipment? So, I think I want to set up that context. I really appreciate, you letting me talk with you today about this. I'm going to have Mary Ann. She's going to come up here and she's going to talk more about screening and how this has been applied and how we've been talking about this within the context of a research project.
All right, good afternoon. Everybody hear me? Cool, okay. So once we started to recognize how often issues around gender-based violence were coming up in our therapy sessions, we began the process of implementing screening questions as part of our annual psychosocial assessments. We're curious how many of you do this, but we didn't have that fancy polling device this year. And so when it comes to the question and answer part, if anybody wants to share their own experiences, we are curious about that. But at any rate, so we started trying to implement, we contacted our hospital-based program that provides coordinated care for patients, families, and employees experiencing interpersonal abuse. And we asked if they had specific screening questions that we could use, but they didn't. And so we kind of created our own. And we can share some of our advice. The first is to start with a framing question to introduce the topic and explain why we're asking these questions. And I hope this is something people are already doing with their mental health screenings. And so for GBV, it could be something along the lines of, we've started talking to all of our patients about safety in relationships, because we know that people with chronic health problems are at higher risk of being in unhealthy relationships. And we know that this can have a large impact on your health. We also recommend that you screen alone. Again, you may already be asking family and friends to leave the room for your mental health screening, but if not, it's pretty critical that you ask them to leave for this. Screen everyone. This reduces bias by ensuring that you're not only screening people who fit your perception of those who experience GBV, offer in native or preferred language, and use a person's pronouns. These are some examples of questions that could be incorporated into screening. They're really just a starting point for conversation. For example, the question about ever being insulted or humiliated. Maybe we feel like everybody's insulted sometimes in a relationship, and maybe you think it's not worth asking about. But if it's happening for our patients, we just want to dig a little deeper. Like, how often is this happening? Is this a pattern? Oh, goodness. Okay. Sorry. Okay. Sorry. Similarly, if a partner always attends appointments with a patient, is that a sign of support or control? Brooke had a patient who left her a voicemail saying, "If my boyfriend's in the room, please ask him to leave." So the patient needed to speak with Brooke about some red flags in the relationship and wisely thought to make this request. Some of these questions might feel invasive or inappropriate, and we might worry about asking questions about a problem that we don't have a solution for. I want to remind you that there was a time that many of us felt the same way about asking about depression or suicide. And I think some people maybe still feel that way. But I think for most of us, when we look back, we realize that those conversations have been priceless. And for many in our CF community, that was the first time they had permission to speak about feeling depressed or anxious or suicidal. And it was the first time they were able to share that burden with somebody else. And so I would see this in a similar light. We've had, from our experience in asking patients these questions, patients often respond with a question of their own. And they say, "You mean I'm not the only one?" And I think it's very validating for people to be asked these questions. All right, so now I'm going to backtrack a bit. So Brooke was speaking about our poster in 2017, and now it's 2023. So like, what happened? So a few things happened. So Brooke had a sweet baby boy who's wearing a bow tie in this picture. And I got a sweet puppy who is on a log in this picture. And the North Carolina Tar Heels won the national championship and got the redemption that they so deserved. And a few other things happened as well. And Brooke's life and my life kind of took us away from the world of CF for a little bit there. And when we try to look at what happened regarding GBV and CF in the years between 2017 and 2023, we find that really, I don't think very much happened at all, perhaps nothing. Okay, so then in 2021, Brooke and I rejoined the CF team as study therapists for CJ Bathgate's CALM study. The CALM study encompasses delivering a tailored cognitive behavioral stress management telehealth intervention for persons with CF. And so as the study therapists, we met with study participants for 6 telehealth sessions in 8 weeks, and then we did 1 booster session. So this is the topic of the topics of the sessions, the 6 sessions and the booster. And no sooner, so if you look at these, actually, you can see there's no topic around GBV. There's no topic around safety or communication in relationships. And yet, as soon as we started this study, these themes were arising again and again. We heard it in session 1. This is the first time I've ever used animations in a PowerPoint. Look at that. Okay, so we heard it in session 1 when we were talking about the fight or flight response. When attempting to engage the rest relaxation response with our participants as opposed to fight or flight, we had folks ask us, how am I supposed to relax when I need to be hypervigilant for the man who attacked me? Oh. Okay, we heard it in session 2 when we talked about balancing unhealthy automatic thoughts with healthier ones. Participants who felt like a burden for much of their lives often ended up in relationships that unfortunately further cemented this view. Participants identified thoughts like, I'm worthless, I'm sick, I'm going to die young, and I can't have children. Why would anyone want me? This pattern of perpetual negative self-talk that stems from patterns of abuse made it hard for participants to identify alternative, healthier thoughts. They had difficulty recognizing their gifts and showing themselves grace. And as Brooke pointed out, these factors contributed to difficulty considering the possibility of leaving unhealthy relationships. We heard it in session 3 when we had conversations about social support, where participants acknowledged being isolated by their partner from family and friends. And in our conversations about healthy communication, we often recognized gaslighting. We heard it in session 4 when we had conversations about prioritizing self-care. Again, participants sometimes had difficulty seeing themselves as worthy of prioritizing, and some recognized that they were using alcohol, marijuana, and other drugs as coping skills. One person voiced uncertainty as to how else she might cope with triggers in the medical setting that reminded her of her sexual assault at the hands of a medical provider. We heard it in session 5 when we discussed coping and problem-solving skills, and we looked at what parts of a stressor were under or not under a participant's control. A lot of participants recognized that they'd historically had a sick role in their relationships and had not exerted much control. One person recognized that her partner didn't actually like it when she started Trikafta, and she started to feel better, and she started to voice her opinions and her preferences. Okay. And we also heard it in goal setting. In some ways, we were not surprised at all to hear about these issues of power and control. We knew that this was out there. But in other ways, we were honestly stunned. We were not asking about this, but the pervasiveness and seriousness of GBV in our CALM participants was overwhelming. So we wanted to speak out to kind of let others know what we were seeing and to see if other people are seeing similar things in their clinics. And we appreciate the NACFC and Mary Beth and Rachel for giving us the forum to do this. And we're hoping to secure funding to study this topic further. Oh. Okay. So now we can move our lens a little wider from GBV in CF to GBV in people with disabilities. So we're doing a little better there. There's been some research, but still not much. This study from 2021 is the first systematic literature review to look at the frequency of intimate partner violence in women with disabilities that takes into account both the differing types of violence and the differing types of disabilities. So they looked through 5 databases covering 26 years from 1997 to 24 years, from 1997 to 2021, and they found a total of 26 articles, which doesn't feel like very much to me. What they did find was that there was a significant association between having a disability and experiencing violence. And now we can move our lens a little wider to look at GBV in the United States. You can imagine how thrilled we were when Brooke texted this little thing that the White House has made a plan to end gender-based violence. The executive summary states, in the first ever U.S. national plan to end gender-based violence, the federal government advances an unprecedented and comprehensive approach to preventing and addressing sexual violence, intimate partner violence, stalking, and other forms of gender-based violence. This initiative builds on the lessons learned and progress made as the result of tireless and courageous leadership by GBV survivors, advocates, researchers, and policymakers, as well as other dedicated professionals and community members who lead prevention and response efforts. So I feel like this shows it's like an important topic. Okay, so we're going to end with some resources. This is a poster that hangs in every bathroom at UNC. Patient bathrooms, employee bathrooms, all the bathrooms. And if you can't see, I hope it's clear, but it gives examples of safe relationships and unsafe relationships. And I just see this as a wonderful way to normalize the conversation about safe relationships. For those of you who don't have a program like this in your institution, or even if you do, these are some, I used animation again, these are some other resources that will help you just gain more information and help you talk with your clients. Okay, we're going to end by thanking a few folks who have supported us. First, thank you to the CALM team at the National Jewish CF Center in Denver for bringing Brooke and I back into the fold. And second, a big shout out to the UNC Marsico Lung Institute and the Adult CF Center. When we first started working with CJ, she said something along the lines of, if you find a pulmonologist who supports mental health care, hang on tight and don't let go. And that's exactly how we feel about the providers at UNC, and especially about our PI for the CALM study, Jen Goralski. Lastly, we want to thank the persons with CF who have trusted us with their disclosures of gender-based violence. And here is our contact information. What have I done? Oh, more animation. Okay, here's our contact info. We're happy to take questions. Now I guess.
Awesome. Yeah, absolutely. Thank you so much.
Does anybody have any questions from the audience that would want to step to the mic? I was wondering if you talked a lot about screening and interventions that were helpful. What are your thoughts about strategies for prevention, like with our younger CF patients?
So I think that is a lot of conversation, but also modeling healthy relationships and communication. I think a lot of modeling and talking about consent for procedures, all of those things, like the context of that, just in any relationship for young folks, I think is just so important. Like if we are asking, like, is it okay if I sit down next to you and we talk for a little bit? Is this a good time? When they're admitted, if they are, getting an IV, like which arm, right or left, like giving choices and asking questions and just approaching that with, basic kind of human interaction and respect, but modeling that consent. I think about it, seeing a picture of my son, I also have a daughter. But I think about that just for my young kids and thinking about like family members enforcing hugs, and really just the context of what that sets people up for long term. And, it's all of these little moments, right, that add later in life when people are trying to.
Okay, go ahead.
Yeah, I had a comment, just kind of going off what you were saying right there, is how much coercion may happen in families as kids are growing up to get treatments to happen and things like that, and with medical teams potentially. And if you all just have any thoughts about how we can, again, from an early stage, kind of avoid this cycle of people being coerced into doing things throughout their life.
I think that's huge.
Meg. We can talk about that too if you want. So we can talk about that some in trauma-informed care, and we say, like, when we think about actions we can take, if you've got a kid with anxiety or you have a patient of any type of anxiety, giving choices is a great option, but only if it's actually a choice. And so I think too, like when you think about setting things up of these are the expectations for your health, really clearly stating you need to take this, like these are the expectations, this is not a choice for you, versus these are the things you have a choice about, and being really clear about what's for your health and what's not. It's going to be tricky in some families where they weaponize certain things. I'm sure you can think of some families, or threaten that you're going to go to the hospital if you don't do your treatments, as a where sometimes they might just have to go to the hospital because they're sick. And so that gets really sticky, but just making sure that we're only making choices when we have them. Thinking about, though, especially in context of relationships and DB, and maybe you all can talk about this more too, but like if it's physical touch of your body, and making sure that one of the things that we know for kids or teens or presumably adults, so I'm not a grown-up person, is like going in the room in the middle of the night, for example. So we did a pilot when I was out at the Children's Hospital in Philadelphia, where we had families ask, like, do you want us to wake you up if we come in the middle of the night? Because sometimes like entering in the middle of the night can trigger not only the patient, but also a caregiver, depending on their history too. So thinking about in our system where our trigger points and setting up kind of systematic places where you can try to follow that. I don't know if you guys have thoughts around those kinds of things.
Yeah, I think that's a really great example. I will also just really kind of put in a basic plug. I think I see, I work with other social workers, of course, and I think that sometimes there's a real struggle to ask loved ones to step out of their room. And that really is such an important thing. I think that you can structure the conversation in such a way that, feels good, and maybe it's setting it up as to, do you have anything that you would like to talk about now, and then out of a conversation, with your loved one, and you can wait in the lobby, and then I'm gonna bring you back in at the end. But kind of to the point of Mary Ann, that patient who I had never met before, left a voicemail for me and said, hey, if my boyfriend is in the room, please ask him to leave. And so I do just want to kind of put out a shout out really to the UNC Peds team, because clearly the care is so good that she trusted someone she had never met to handle it, and to do what she asked by communicating through the voicemail. So I really appreciate all the Peds providers and to setting us up for success in that situation. But asking people to leave and being able to have conversations and picking up on clues of looking at symptoms, and also just longevity of relationships. I don't think any of these things come out the first time you meet a person. Like, these are the things of, planting seed and watching it grow, being able to be with people around.
There's a couple questions about what if the family member won't leave, or what if there are children in the room and then you're unable to contact them by phone afterwards?
Yeah, I think that those are really, really great questions. I think our team probably works in such a way that we might have some specific ways to handle that, where, we had 2 social workers, and so maybe it would have been a possibility to grab Mary and have her work with the kids, while I am talking to, the patients. If people are not willing to leave, then I think maybe you have a red flag.
I think we also have used colleagues in that situation in the past, where we would ask maybe the pulmonologist to pull the parents from the room so that by coincidence we're left with just the patient. Just ask for some help.
All right, well, thank you again both for this really important talk, and we'll have some more time at the end for questions. So our last speaker is Joy Clymer. She is a licensed professional counselor in Pennsylvania and a behavior health specialist in the pediatric specialties practice of Lehigh Valley Riley Children's Hospital. In this position, she operates as the mental health coordinator for the CF Foundation Core Clinic at Riley Children's Hospital. She has experience treating interpersonal trauma, trafficking survivors, and medical trauma. Joy is a trust-based relational intervention, or TBIR, practitioner and a making sense of your worth facilitator, or MSOYW. TBRI and MSOYW are evidence-based trauma interventions designed to address trauma by improving attachment, self-efficacy, and self-worth. She implements these in her role to address medical trauma, which improves family relationships, behavioral disruption, and treatment compliance. She holds her certificate in global trauma recovery from the Global Trauma Recovery Institute, and has extensive international experience, which has honed her cultural competence and ability to apply models across varying milieu. She's active in her faith community, conducts groups with trafficking survivors on behalf of the Salvation Army, and volunteers as a survivors counselor for VAST, the Valley Against Sex Trafficking, a united movement in the Lehigh Valley of Pennsylvania to empower survivors of commercial exploitation. So welcome to Joy.
So in advance, I want to apologize to this side of the room because you're not going to be able to see me at all, even with my heels on. So I do apologize for that. Thank you so much for this opportunity to tell you about trust-based relational intervention. I just love it. It's close to my heart, and so I'm excited to share it with you. I have no relationships to disclose related to this presentation. So just before I start, how many of you here have heard of trust-based relational intervention, a trauma therapy created for addressing the complex needs of vulnerable children? I see your hands. Of those, how many of you are TBRI practitioners? Anyone? One? Okay. Yeah. So if there's any others here that I didn't see, I'd love to connect with you and talk with you a little bit more while we're here at the conference. So please feel free to reach out to me. And for those of you who may wish to learn more about this model, a TBRI practitioner near you is where you can find more. So my focus today is going to be on applying TBRI to the CF clinic rather than therapy, because that's the broadest application for this audience, obviously. And anyone who provides care can be trained in this model. And I think it would be great if everyone on a CF clinic team were trained in this therapy model. It's a rich and effective intervention that improves outcomes for those who've experienced trauma. But please keep in mind that what I'm sharing with you today is like reducing a fire hose to a cup so that you can have a sip. It's just a little bit so you can have a taste of it. So what is TBRI? It's an attachment-based, evidence-based, and trauma-informed intervention. It was designed for children who've experienced maltreatment, abuse, and neglect, which we could also call interpersonal trauma. However, it is applicable to all sorts of trauma. It's been implemented in homes, schools, orphanages, juvenile justice facilities, trafficking aftercare homes, and a number of other settings. So also, because this model was designed originally for children, I'll be referring to children throughout, but with a little tweaking, you can easily transfer the principles to teens and adults. There are a number of factors that can result in trauma responses in children. A difficult pregnancy can result from medical issues, maybe drug and alcohol use, life crisis, or other trauma that are at-risk factors for babies. Additionally, a persistent high level of stress throughout pregnancy elevates the risk. A difficult birth can lead to mild neurological insult. And hospitalized babies experience painful touch rather than nurturing, comforting touch in the first days of life. I know of a baby who was in NICU for 8 weeks after her birth. She's now about 8 months old, and she begins to cry upon entering the hospital lobby. She becomes increasingly dysregulated when in the doctor's office. Other things can be abuse, neglect, and trauma. So trauma in general causes a child's development trajectory to change in response. Let's pause for a moment and take a minute to consider medical trauma. I want you to think in your mind, would you classify medical trauma as an interpersonal trauma? I think we can all agree that all the adults involved, doctors, nurses, technicians, parents, everyone means well and is acting out of genuine care for the child, even if things that are done are painful. However, a child can't comprehend that level of abstract reasoning until they reach adolescence. So this slide captures a child's perspective of medical trauma. And as you can see, it's kind of personal. So from a child's standpoint, I think we can say that medical trauma qualifies as an interpersonal trauma. With this insight, consider the CF kiddos and families you know and the trauma experiences they likely have experienced. The encouraging piece is that trauma that comes through people can be healed through people, and you have the power to bring healing to kiddos and families through routine office interactions. I'm not saying that their entire trauma will be healed, but you can begin to bring healing. You can begin to counteract the impact of the trauma on their lives. So in a study at the Center for Family Development in Williamsville, New York, Dr. Arthur Becker-Weidman found that a child with complex trauma can act less than half their chronological age. Less than half their chronological age. So it is imperative that we view kiddos' behaviors through the lens of trauma to ensure that hurting children receive healing care rather than being re-traumatized. Let's explore some common ways children express fear and pain. On the left, you can see internalizing behavior. Now, as you look at those, think inside. What's your normal reaction to behaviors that you see like that in a child? Generally, it's compassion. You want to move toward the child. You want to help and assist. You want to see what they need. Now, on the other side, we see externalizing behavior. And think inside how you tend to respond to externalizing behavior. Usually, we tend to respond with power, correction, and we want to move away from a child like that. But this can actually re-traumatize and hurt them. So one thing to keep in mind is that because these are expressions of fear and pain, reducing their fear will often reduce these behaviors. So to help children feel safe, it's important that we explore the concept of safety. Think in your mind for a minute. How would you define safety? Merriam-Webster defines it as the condition of being safe from undergoing or causing hurt, injury, or loss. Karen Purvis, one of the founders of trust-based relational intervention, defines it as the state when a child feels in a profound and basic way that he is truly safe in his environment and with those around him. So you can see that even if a child is technically safe, he may not feel safe. And if he doesn't feel safe, you will see the behaviors that we saw on the previous slide. I want you to think about a child that you've encountered in your clinic, behavioral issues with a child in your clinic. And think for a moment, do you believe in hindsight that that child had a sense of felt safety with you and your staff? Increasing felt safety is at the core of TBRI. Now we're going to move into implementing TBRI principles. There are 3 key things that we can do that powerfully impact the impacts of trauma: pursuing connection, reflecting preciousness, and giving voice and choice. We're going to consider each of these in turn. Trauma that comes through humans, even well-meaning ones, injures trust. Connection with safe people restores the security that was lost. Nonverbal connection is a key aspect of connecting with a child, and we can do this in important ways through like a soft voice and a lilting and playful voice. Gentle eye contact, behavior matching, which is basically doing what the child is doing. Healthy or symbolic touch. So symbolic touch is where you might reach out as though you're going to touch the child, but you don't make contact. This is good for children who you're not sure of their background. Have they had unsafe touch in their life? It's also good if they maybe don't feel ready for touch. It shows connection without actually having to touch them. So it might look something like this. So let's pause here to explore how to make medical touch feel safe. It's important to note that touch can be harmful even if it's not intended. So explain how you will be touching them and why beforehand. Give choice around touch. Ask permission before touching and offer non-clinical or symbolic touch to kind of offset the clinical touch. So here's an example. You walk into an exam room and you offer a high five with a warm smile, and in a lilting voice you explain that you're going to need to take their temperature across their forehead, their blood pressure on their arm, and listen to their lungs under their back, under their shirt. And then you ask them, which would you like to do first? They say blood pressure, and you reply playfully, okay, great, will you do your blood pressure first? Good choice. May I place this handy dandy cuff on your arm? Something like that. So here are examples of good non-clinical touch that can offset clinical touch. And remember, if they don't want to touch, that's perfectly fine. But be sure to try to connect with the child emotionally with that gentle eye contact, a warm smile, and a friendly wave. The connection is the most important piece. Mindfulness is being aware of yourself and thoughtfully considering your internal response through questions like those listed here. We're going to explore this concept a little bit more with a clinical example of 5-year-old Eli. We're going to call him Eli today. That's not his real name. So when getting an injection at his PCP's office, Eli wriggled free, escaped the exam room, and ran into the hall crying. I want you to consider what your internal reaction might be if you witnessed that event at the doctor's office. What might your first reaction have been? prior to receiving mental health training, my automatic internal reaction would have been that Eli needs to stop the drama and his mother needs to control him. And that's because as a child, I was not permitted to make a fuss in public, right? So in situations like these, I need to really consider and question my automatic conditioning. The internal and external fear reactions that we looked at before invite us to cultivate curiosity about Eli's backstory. So let me tell you a little bit about Eli's backstory. Eli experienced a difficult preemie birth and was in NICU for a month. During his first weeks of life, he experienced needle sticks in his heels multiple times daily to monitor his blood sugar. From his perspective, no one was able to rescue him from this situation. He sometimes went without comforting touch when his parents couldn't be there due to work or family obligations. And Eli has scars on his feet to this day, and he also still to this day will not allow anyone to touch his heels. He is deathly afraid of needles. So as we see by his backstory, Eli is not being bad. He's having a trauma reaction, much like a combat veteran who falls flat to the ground when he hears a car backfire. It's not a choice, but a visceral response to a perception of danger based on his past experience. Eli needs empathy, skills, and support to overcome his trauma. Now we'll look at at reflecting preciousness. Trauma impacts a child's sense of worth. By empowering a child, we demonstrate they are precious and their preferences and their needs matter. Internal physical needs are crucial because when blood sugar or hydration dips, the brain is more likely to flip into fight, flight, or freeze response because it registers vulnerability in the body. You see there are a number of sensory items on this list. Sensory input helps the brain to organize itself and helps a child to self-regulate. The proprioceptive sense is deep muscle pressure, and vestibular sense is where you are in space, movement in space. Both of these are very calming, which is why we swaddle and rock babies. One way that I implement play is to invite children to play hot lava going down the hallway of our office. They hop from colored tile to colored tile, and they absolutely love this game. And it's great because it provides proprioceptive stimulation, vestibular stimulation, and distraction. So it helps them to feel calmer as they're walking to my office. So there's also external environmental needs. Transitions are important because many children with trauma struggle with transitions. Many of the transitions that they've encountered haven't been pleasant. And the unknown is very unnerving for anyone who's had trauma. So we need to announce transitions and timing in advance, announcing who's going to be coming into the room next, how long they're going to be here. Let children know what to expect ahead of time. And this is something to address with parents if they're bringing children to the office and not telling them what's going to be happening. That needs to be addressed with parents. Children should know in advance what they're coming to the office for. Rituals mark events and provide a feeling of routine, familiarity, and belonging. They're usually used to open or close events. It can be a special handshake, a greeting, or a rhyme, or a special dance. I'm sure everyone has seen that viral video of the teacher who has a different special handshake for every child coming into his classroom. That's a ritual. And kids love it because it's like, I belong here, I have a place, I know the routine, I know what we're doing. We have a thing that starts this event, we have a thing that closes this event. We want to mitigate pain whenever possible and be proactive about addressing pain because this shows a child that they matter, that they're precious. A great way to proactively address pain is to visit megfoundationforpain.org. It's a fantastic website. They've got a procedure or poke plan that you can print out and complete with children. And we're going to look a little bit more at that shortly. I'll put it up on the screen for you to see. They explain comfort holds. They demonstrate the proper use of numbing cream. And they also explain how pain works physiologically to help caregivers understand how they can provide support. Another great way to help kids is to help them create a comfort kit to take to the office with them. A comfort kit can include things like an ice pack, a special toy that they only get when they're doing a medical procedure, distraction items, healthy snacks, water, and gum or lollipops, because those the act of chewing and sucking on things is very calming for children and adults, actually. Okay, let's go back to our 5-year-old Eli. So to prepare him for procedures in our office, I worked with Eli's mother to improve nurturing communication. Now, she already told her son she loved him, but I encouraged her to emphasize her love and for her to emphasize how precious he is to her, and also to explain that she takes him for injections and procedures and takes him to the doctor because she wants to care for him well. Now, many parents say that right as they're taking a child to the doctor, but what we needed to do was to increase those conversations in normal routine times of life, when she's putting him to bed, when they're sitting over dinner, when they're playing together in the playroom, so that it normalizes the conversation and it's happening during a time where he's able to absorb the information. When a child has heightened anxiety because they're going to the doctor, they can't absorb concepts and ideas and languages easily. So that's really not the best time to tell them that that's why you're doing that. So we increased that to other times. She also encouraged Eli to ask the doctor questions to help him start to really realize he can ask questions and he can get his worries and fears talked about when he's with the doctor. I also worked with Eli's mom to assure her that we could mitigate the pain that Eli feels. This actually really surprised her, that we could mitigate some of the pain. And it might for many people. I'm sure many of us grew up during the age of grin and bear it, right? And that's just how we got through things like that. And so many parents have no idea that there's things they can do that can reduce the pain that their child feels. So I had her go to Meg Foundation for Pain. She watched the videos on there that explain how pain works and how to interrupt them. There's also articles on that website. She read those articles. While she was doing that, I worked with Eli and helped to reduce his automatic trauma reaction through gradual exposure to medical equipment. We used syringes without needles and looked at pictures of injections. We watched videos of injections. We practiced putting the syringe, just touching his arm. We practiced giving each other shots and, giving each other little pinches. Obviously, you would ask before you do that. Don't do that to a child who doesn't say, yes, you can do that to me, and don't pinch too hard, right? But it's just to get the idea of it, like getting him acclimated to the thought. I also ensured that his mom knew the correct way to use numbing cream, that she knew how to put it on and how to use it and how to get it on early enough. And we practiced using a Buzzy for shots. If you haven't seen one of those, you can find it on Amazon. They work really well. They're great. And some families maybe want to get one. You might want to get one for your office. They're great to have on hand. Next, we're going to unpack voice and choice. Trauma takes away personal agency, voice and choice. So restoring personal agency works to reverse the powerlessness of trauma. So encourage kiddos to use words and whole sentences to express needs and desires. You can do that simply by saying, can you use good words to tell me that? If they point to something or if they just say one word, have them ask you in a whole sentence or tell you in a whole sentence. It's empowering to them. It helps them learn to use their voice. When they do express things, listen closely for the need that they're expressing and for the need behind their behavior if you see behaviors. And do anything you can to say yes to the need, not necessarily to what they're asking for. They may ask for McDonald's, but the need may be that they're actually hungry and they need a snack, right? So getting them a healthy snack that is appealing to them is meeting that need. It's also best to use forced choices with children. That would be 2 good options only. Now, the emphasis there is on good options, right? Offering to sit on the bench or be held down is not a good choice, right? That's not a good option. Good choices might be like, would you like to sit on the bench or on mommy's lap for your exam? Would you like the lights high or would you like the lights low? Would you like to check your ears or your throat first? So, and if they refuse to make a choice, you can gently let them know that if they don't choose, you'll choose for them. But if you do that, try to choose the most appealing thing that you think they might like. Remember that playful engagement helps children feel at ease. It is their natural native language. So playfulness at any time, even when they're misbehaving, playfulness can often disarm or redirect a child very quickly. Let's go back to Eli. We helped Eli create a POKE plan, which you can see here. It's little excerpts of it. Basically, a POKE plan or a procedure plan is a detailed outline of his preferences for the procedure. Which arm he wants it in, who he wants standing next to him or sitting next to him, whether he wants a sensory toy or not, all kinds of different things. It's about it's about 2 pages long, I think, and it's a great resource. And he had a lot of fun putting his together. He knew exactly what he wanted. He knew his answer for every question, and he was happy to tell us what it was. We also practiced comfort holds with his mother to identify the comfort holds that he liked best. And we identified his preferred items for his comfort kit. And then Mom and I reassured Eli that he could do this. And he was so confident by the time we were done with all these things. This last time in my office as he was leaving, in his little 5-year-old voice, he said he was ready for his injection. And I was just really proud of him. So while they were practicing at home, our office also was creating a smile cart for kiddos with procedural fears. And our smile cart contains things like a buzzy for shots, ice packs, numbing creams, sensory items, snacks, drinks, distraction, iPad, and prizes for when they have a good successful procedure. On procedure day, Eli came to our office and he brought his POKE plan and his comfort kit with him. And our nurse reviewed the plan with him to make sure that there wasn't anything that he wanted to change before they began. And he stood by all of his answers that he had before. He knew exactly what they all were. And his preferences were honored. Now, he did at first attempt to grab the syringe. And so they did explain that they needed to hold his arm down, which wasn't part of his plan. But they explained why they needed to do it for his safety and for their safety. And he agreed to it. And he didn't fight them. He did cry a little during his injection, but then he quickly returned to baseline. And he was very promptly asking his mom for his pre-selected reward, which was going to the park afterwards. And he was very excited to do that. He was very, very proud of himself for succeeding. In fact, he was so proud of himself that he encouraged his 14-year-old brother to come to me for injection anxiety as well. Now, there will be times when children get really dysregulated in your office. And the first objective with a dysregulated child is to help them to calm so they can use their voice and their choice. A child cannot reason, process language, or communicate when in fight, flight, freeze response is in control of their brain. So in these cases, we want to calm them so that we can find out what we need and meet the need. And I like to use bubbles or even a pinwheel to make deep breathing fun, because kids don't want to just sit there and breathe deep with you, right? They don't want to do that. They want to cry, but they can be distracted with bubbles, and they love bubbles and they're deep breathing. So it's perfect. So this was a very small taste of TBRI as applied to the CF clinic setting. I'd like you to remember those 3 things that you can do, which is, what were the 3 things? I forgot. reflect preciousness, voice and choice, connection. And these are the things that you can do to help counteract trauma. If you'd like to learn more about getting your CF clinic trained in TBRI, please reach out to me. Or if you'd like to learn how to implement this model in a therapy setting with families that are experiencing behavioral problems, you can reach out to me for that too. I'd be happy to hear from any of you. And there's resources on the slide here that you may wish to look at. Thank you.
Do we have any questions from the audience? I loved what you just talked about, Joy, because I'm thinking of the 2-year-old that came for his yearly and easily went down the hall with me to tag the next person after I spent hours rocking him inpatient. And I'm just like, that was good. And then the 22-year-old who requested an Uno game during his clinic visit after he and I spent hours playing Uno. So I'm thinking of those rituals and that's just very validating.
Yeah, that's right.
I feel like I just ran a 5K to get over here. Sorry. I'm a social worker. My name's Melissa. I work at Boston Children's Hospital, as well as Brigham and Women's for the pediatric and adult centers. Thank you so much for this session. I have so many thoughts. Basically, to all of you, how do we make this more than just the social worker's job and the psychologist's job? Because we can only do so much, and sometimes we only have 10 minutes in a room with a patient. And I find that all of our providers are very, very well-meaning, but they are trained in medicine. And they said, all that stuff is well and good, but I'm here to treat their exacerbation and get them home, or I'm here to get their PFTs and tell them what they need to do. So I would love if you have any insights about how you've helped other team members do these types of trainings, because it's something I think is very needed and I can't figure out how to do it.
I can start. I think a few things. Who also is getting tagged in on this is the nurses, and then they're getting a little bit as well. So I think really thinking about, can we frame it for any of our medical colleagues to how it's going to make their job easier. So if you implement systematic psychoeducation or build in how you're going to explain things to kids in a way that's going to shorten the amount of time in the long run, and let them see more patients and let them spend time on other things. Sometimes that's a strong selling point. Emphasizing the importance of the relationships. A lot of times our medical providers see kids and families for years and years and years. And if you also offer it as a way to build relationships with the patients and lay that trusting foundation. I know the medical teams that I work with deeply care about their patients and families. So if you frame it as this is another way to show your patients how much you care and to care for your families as a whole, and that whole perspective, sometimes that can help as well. The other thing we've done sometimes with trauma-informed care trainings is we've identified champions within the teams that are not social work or psychology. A lot of times we'll find a nursing champion or sometimes a physician champion, and then those are the individuals, once you've kind of laid the foundation, that are taking it forward and trying to integrate it into every daily rounds or every case consultation. And so if you can identify those key players, we've had some success with that as well.
I was just going to add, I know that this is tricky in time management as social workers and nurses, but I think there's a lot of team members that don't just respond to data. And so in some way, keeping track of how many times you're having this same conversation over and over and over and over and over again. And being able to present that at some sort of staff meeting or some sort of, NACFC and poster presentation. I think it's going to take all of us kind of continuing to have this very, real conversation about how we're spending our time to continue to get buy-in.
I also think that if approaching it rather than a whole new thing to do or another thing they have to get, but like you said, there's a great love for the patients and a great connection with the patients. And if we can frame it more as with a few tweakings of how you're interacting with patients, you can actually be bringing even deeper healing than you already are. Because I think at the essence of it, people go into medicine because they want people to be well. They want to help people to be better than they are now. And so that's just kind of tapping into their deeper motivations themselves. And so it's not adding another layer. It's just some tweaking with some ways that you're interacting can be really powerful.
Hi, I put this question in the Q&A as well. So my name is Marnie and I'm a child life specialist, and I'll just make the general comment that a lot of the interventions that you talked about, especially in the case of Eli with building a coping plan and doing medical play, is all within the skills and competencies of your child life specialists. And I've beat this drum, I swear to death, over the past 10 years, but we often forget that child life has a place in the outpatient clinics as much as it does in the inpatient. And we need all of you to help our administrators and our healthcare leaders understand that it's not just that our CF patients are getting physically better, but they are going to have immunizations in their primary care that is going to affect how they walk into our CF clinics and then become young adults who may or may not seek out care as they get older. So we talked about that in our Lunch and Learn, which was the biggest child life Lunch and Learn roundtable that I've seen at CF conference. So thank you all for your support, and please continue to partner with us to get us into those outpatient spaces.
I also think, like, in context of that too, child life has a lot of opportunity and skill sets for prevention. And so sometimes you might not be able to have the psychologist or the social worker see kids in a preventive manner because of billing and whatnot, but oftentimes child life can kind of set the stage and prevent maybe some of the distress from occurring in the first place. So it's a great role to integrate in.
We have a question about suggestions to help a 2-year-old who has a meltdown whenever it's time to do her respiratory culture.
Yeah, so I think that it would be really important to find out kind of the story a little bit more behind that, to find out, has she always just had a bad experience with this? And then also to find out, what's the situation? Is she being prepared in advance at home? Is mom kind of trying to prepare her a little bit for that? And finding that out first. And then we need to try to desensitize and provide choice. Even 2-year-olds have opinions. So providing choice. And that would be like, I would encourage, like, is there a comfort hold that might be helpful? If a child is, reactive to sensory input, maybe they would prefer the lights to be down low. Little things, making sure mom knows to make sure she's dressed in clothes that are very comfortable for her. Again, it's that sensory piece. And that she has a reward lined up in advance afterwards. Yeah, that's what I have right now off the top of my head. But if I was seeing the child, I'd be asking a lot more questions to find out more about the landscape around the whole situation.
We've had a lot of success recently too, especially with the younger ones, with social stories, creating individualized social stories. And a plug for Jess Smith-Thomas has a poster on social stories tomorrow, I think. If you want to see some templates, or reach out to our team for ways we've set up templates for some of our CF kiddos.
Hello, just commenting on the throat swab. I'm a former child life therapist and then went into social work, and now I do mental health coordination, but also bring the skills of my previous career into the clinic. And one of the interventions we use for the throat swabs is getting kids to just paint with throat swabs with just washable paint. We also have a Play-Doh mouth that was a dental kit, and we'll put germs in there and let the kids get them out. So just desensitizing through that. Very affordable, portable. There's a lot of different things. Please consult, just like we heard before. Get your child life people in and do some of these skills can definitely be cross-trained as well. And I'm hoping that the foundation represents that profession much stronger than in the past, because I've been coming to NACFC since 2000, when I was in child life, and wondering why I was one of 2 or 3 people and there weren't any tracks for me. So this is the best place for us, but I think we need to really, get that role definitely much more visible within NACFC. Thank you.
I'm Shayna Blair. I'm a clinical social worker at Children's Healthcare of Atlanta at Emory University. And And I will just share, so our team has been doing a lot around procedural anxiety for the last several years, and it's been multidisciplinary. And just within the last couple of months, we actually had our child life specialist come and spend an hour with us over lunch. And we just, they taught us some skills that, our team can implement in clinic. But the one I wanted to share that could be helpful for this 2-year-old, and this is what I learned from a child life specialist, but they modeled for us, do you want to be a dog? Like, do you have a pet at home? And, if a kid really connects with that, can you pant like a dog? And so everybody in the room is panting like a dog, and they're kind of opening their throat, and it's kind of that therapeutic play. And anyway, so our team, was into this. So I just wanted to mention that too, is we don't have outpatient child life, but that's one of the ways that we've tried to get creative and collaborate, and also kind of give them a presence, and, kind of sort of advocate for that role too.
Thank you, Shana.
Yeah, so I think a lot of great ideas around procedural anxiety, and as we, hope that the landscape of CF is changing, there are definitely still procedures that are going to be involved in care. So important to think about that. I was curious, thinking back on Brooke and Marianne's presentation, we joked about not having the poll, but I was curious how many of you all do screen for interpersonal violence, perhaps even within pediatric clinics, how often we're asking parents about that, and if that is also something you all have seen in your clinics. So let me ask, how many of you all are screening? Okay. We have time for a few more questions. Anybody can put them in the app or come up to the microphones. Any last minute thoughts from the panelists as well? Well, thank you. All right, we'll give you 10 minutes then before the next thing. Thank you so much to our presenters, and thank you all for coming today.